try to do with this program is try to address some of the common questions that we get in our clinics, and especially now around the use of belzutifan. How do we think about family planning? How do we approach the use of belzutifan around that time? And what options are there for patients with VHL, depending on how they want to pursue family planning. So we have two speakers, Joe Letourneau, who is a reproductive endocrinologist and fertility expert here at the University of Utah, and co-director of the Onco-Fertility Clinic. So he'll be speaking more on the female side of family planning.
Thanks for having me, everybody. So I'm a fertility doctor here at the university, and I do reproductive endocrinology and fertility, which sort of sums up to a lot of people think of me as like an IVF doctor, so that's what I do commonly. So I help people with infertility, just like Dr. Gross, but one of my areas of interest is to help people with cancer diagnoses or cancer risks. So I'm happy to talk to you today. I do some consulting for a pharmaceutical company, but I'm not going to talk about that today. So our Onco-Fertility program at the University of Utah has been around for almost a decade or so now. We have a comprehensive onco-fertility care program with an objective to advance clinical care and translational research. Within Utah, there are about 1,200 reproductive age cancer survivors diagnosed every year. And we perform about 200 new onco-fertility consults every year. So onco-fertility being sort of fertility concerns for people with cancer. We provide services for people around the Intermountain West, including egg and embryo freezing, talking about expectant management, meaning that we don't perform egg or embryo freezing necessarily, but we just help people understand their future fertility as best we can. So they do sperm freezing, and then we have some more unique programs at the university where we can help people freeze ovarian tissue or even pieces of testicular tissue, which is currently an experimental protocol for young kids. We have the ability to do that here at the university as well. So I'm going to take about 10 or 15 minutes today, and I want to talk about fertility concerns with VHL, some fertility preservation options, and then genetic testing options, which might overlay with people who have been diagnosed with a VHL-associated cancer, but also just people who don't necessarily have cancer yet, but are thinking about ways that they might prevent what we call the vertical transmission of a gene, or basically preventing the transmission of a gene to the next generation. Okay, so I wanted to talk firstly about ways that fertility might be affected by VHL treatments. A lot of the treatments for renal cell carcinoma and things are newer, what we call small molecule chemistry, molecules that affect certain enzymes or proteins, and then some immune therapy. As you probably know well, a lot of the kind of older classes of chemotherapy that sort of just broadly affect cell division or kind of prevent some DNA formation and things and have more broad effects around the body. Those haven't been so successful with some of the treatments for renal cell carcinoma or other VHL-associated tumors. So these newer treatments have become much more effective. I'm going to talk about that a little bit. When we think about fertility concerns, there's basically a couple of dimensions of it. Firstly, we need to make viable cells to make an embryo. And so we need to have healthy ovaries. So here's an ovary, here's a human oocyte or egg with a sperm fertilizing it. And then we need to have healthy testicular tissue and healthy sperm to be able to eventually make an embryo. And I think my slides, there we go. Okay, so once we make an embryo that is a combination of the sperms and eggs, and of course that needs to become an embryo that becomes a fetus and then a baby. We call implanted embryos up to 10 weeks an embryo still, and then 10 weeks to delivery, it's called a fetus, and after that it's a baby, so it's sort of the verbiage around this. But when we think about embryo development, the most critical organ development is between 6 and 12 weeks of pregnancy. So when we think about medication exposure, we're particularly worried at that time. This is when the blueprint is laid for things like the liver and the heart and the brain. And certainly we're concerned after 12 weeks about drug exposure. Drugs after 12 weeks of pregnancy can affect baby viability, their size, and then their further organ development, particularly the brain development. When we think about what we know about medications as it relates to fertility, it's kind of a hard thing to study when you think about a cancer drug. Firstly, cancer overlapping with pregnancy is fortunately not as common because cancer tends to be a disease of age, although it's of course not always. And when people are exposed to drugs, we might think, okay, how does this drug affect their ability to have a baby in the near future or the remote future? But sometimes that future is very remote. We might be thinking about how a drug exposure for a 3-year-old is going to affect their family building. That literally might not happen for 30 years. So studying this is really challenging because it takes a long, long, long time to study. So what we tend to do is we look at animal models and we say, okay, in a mouse model or even in the model of just some cells that help make sperm or cells that are part of an ovary, we might say, what does this look like in terms of egg health or sperm health? The outcome of putting these two together and making one of these is, I would describe as, if I could make an infinity sign, it's infinitely complicated. Like, we don't understand how it works, to be honest. We know some basic steps, and what we basically understand is you need one of these, you need one of these to make one of these. But honestly, the genetics of it are wildly complicated, and we don't really understand it. So, we make inferences about what we can see from cell health and think that might affect, baby development and embryo development. And we also learn through happenstance. So a lot of pregnant women, when we study this, say, I would be happy to take an experimental drug in pregnancy to treat the disease I have so that I can be feeling better and other people can learn from this. Pharmaceutical companies, sort of understandably, they're very hesitant to do any studies of people that are pregnant. And so though people who are pregnant would be willing to be studied and take medicines in randomized trials, they basically never do them. So what we end up learning is someone says, oh, I didn't realize I was pregnant, and now I know I'm pregnant, I've been taking this medication, what was my outcome? And so we have these sort of quasi-studies about drug safety in pregnancy. And interestingly, many drugs are quite safe in pregnancy, and we find that out later. Some drugs are really bad for pregnancy, and we unfortunately find that out later. For most chemotherapy and cancer drugs, the trials that people enter and then sort of the clinical advisement is going to always be, use 2 forms of contraception. So from a female standpoint, use either hormonal contraception or an IUD, or combine that with a condom, if you're of family building age. So we actually actively try not to learn a lot, and the reason we try not to learn a lot actively is in pregnancy we get really worried that if we expose a developing embryo to a new drug that we might affect its organ development, which could end the pregnancy or could yield a baby that has really significant health concerns. So that's sort of the background of how we think about this. How do we pronounce this? Belzutifan. Thank you. Okay, belzutifan. Is obviously, it's a newer drug. So the randomized trial, I think, or one of the big trials came out in 2021 to help establish that this could be really helpful for renal cell carcinoma in people with VHL, again, in the absence of having a lot of great treatments. So really good questions come up. How does this affect eggs and sperm? And I'm sure Dr. Gross will talk to you a little bit more about the sperm side, but just from an egg standpoint, this is a really new drug. I mentioned it takes sometimes 30 years to understand fertility, so we really don't know hardly anything right now about people fertility. So that's sort of the state of the science. We know basically nothing. Okay, so this is more and more common for newer and newer drugs, and the great thing about personalized cancer care is just that. We can personalize it down to the level of a single molecule, but the tough part about that is that we have very little information because different molecules affect different cancers differently and so on. So we've got rare situations with really helpful treatments, hard for us to study fertility outcomes because there just aren't that many. So last fall, the FDA created an advisory sort of panel type thing about this. It said, okay, this is the reality. Fertility after cancer is really important. Newer molecules are really important to give because they're really helpful. We had decades of experience with chemotherapies, and we still haven't even mastered the older sort of sledgehammer type chemotherapies that affect all kinds of cells. When we're really looking at these new ones that have come out 3 years ago, what the FDA says now is, okay, if there's no information at all for people, do this. Look at animal models. So most FDA approval will involve some animal model study of the gonads, and it's usually about a 3-month follow-up study. So like, did a mouse make sperm after they were exposed to something? Did a mouse who had eggs, did they have any eggs left? Did they make pups or embryos, or were those embryos negatively affected? But rarely going to be anything in people. Okay, so let's look at that. What if we had some animal studies? Sometimes we don't. Sometimes there's a really good question about reproduction that's not in an animal study. So then they say, okay, look at the cell itself. Is the target in the cell? Yes. So HIF2A, or I'm not sure even exactly, how do we say this? Do we say HIF?
HIF2 alpha. Yeah.
HIF2 alpha, thanks, okay. So HIF2 alpha is in oocytes. HIF2 alpha is in the connective tissue of the ovary. There is a study in animals that shows that HIF2 alpha can shrink testicles. And HIF2 alpha could presumably affect ovarian tissue. In the short term, it didn't seem to show in a 3-month follow-up in like mice, basically. We didn't see really obvious effects, but it probably could. So little is known about it, but we do see smaller gonads in males. These targets are in the ovaries. They're not always. There's some of these new molecules where it's like, oh, we don't see anything in the ovaries. Well, it probably doesn't affect fertility. So in this case, I would be worried. And we do see that there are reduced sperm counts with smaller testicles. We just don't know that much about eggs yet because it's just a little bit harder to study. HIF2 alpha is also implicated in embryo invasion or embryo implantation in the pregnancy. So this actually assists with embryos implanting. And then, of course, HIF2 alpha is kind of in a lot of cells in the body, so it might affect growing babies as well. Another reasonably common treatment that people might encounter would be newer immune therapies, so medicines like nivolumab and pembrolizumab, which increase immune activity. So they basically tell our helper T cells, hey, you usually go around and surveil for cancer cells and infections and stuff like that. And usually if you see a cancer cell, you take it away. But gosh, there's a cancer cell there. This hasn't stopped it from growing. So why don't we just kind of disinhibit this and make it go more or less crazy, so to speak, and let it really attack all kinds of cells. The problem is these little things here are called antigens. So they're proteins on the surface of a cell. Both of these tissues make a lot of these. So hormone tissues are basically communicators. So they're sending out like Wi-Fi signals. So they're not directly communicating like nerves do. They're sending signals out all over the body. And the way they do that is they send the signals off of the surface of their cells. And so there's lots of antigenicity, we would call it, or lots of interest from the immune system on hormone organs. So this is why people get autoimmune diabetes. This is why people get thyroid disease. This is why autoimmunity tends to affect hormone glands, as the hormones are very active at producing proteins on their surface, and so the immune system wants to kind of keep an eye on them. Because the immune system keeps an eye on hormone tissue, the hormone glands, like the ovaries, the testes, the thyroid, the pancreas, are susceptible to damage from disinhibiting these immune cells. So basically we can worsen autoimmunity toward the gonads. So if someone was getting a HIF2 alpha modulating medicine, if they were getting immune therapy, I would basically recommend that they think about preserving fertility, because we don't know exactly how the other downstream effects are going to occur. Okay, so as Dr. Sanchez says, I mostly talk about ovaries with people, so I'm going to think about how fertility concerns from VHL treatments could manifest in an ovary. So this is a zoom in on an ovary. I'm obviously not an artist. Maybe I can take that class and use some fruit to make art here. But basically this is the ovary here. I tell people when I scan them with ultrasound, and we certainly have anxiety in fertility medicine, I'm going to use that term now, that ovaries look like chocolate chip cookies. And these chocolate chip areas would be basically fluid sacs that have eggs inside. We can see lots of these on ultrasound. There's an invisible part on ultrasound that we can't see, and these are the eggs in the connective tissue of the ovary. And these are basically the egg bank of the ovary. So I sometimes describe this as like an auto factory to people. So we have this bank of materials where you could basically make a car, and then like an assembly line. And this takes about 3 to 12 months to make an egg that can be mature or fertilizable. These eggs might represent like the car frames and the tires and things of that nature. And they have to be sort of assembled in a sense. The egg has to get more mature and developed until it can actually be fertilized. So this egg can be fertilized, these ones can't. So one of the challenges with female fertility medicine is it takes time to get eggs ready. And so if someone's getting a treatment really quickly, we have a limited amount of time to get eggs ready, but it usually takes at least a few weeks to help hasten their development. Okay, so traditional chemotherapies at a minimum would tend to knock eggs off the assembly line. This takes 3 to 12 months to develop. So what that means, if I'm seeing a patient in May, that they might have an egg getting ready for September or November. And if they get chemo, they'll tend to have all those wiped out, so that when they finish chemo, even if there are eggs still in their egg bank, which sometimes there aren't, it's going to take 3 to 12 months before we can see eggs again. So most people that got traditional sort of cell poison chemo, so I'll just call it, it would take 3 to 12 months before they had any fertility development afterward. And then we would typically recommend, if someone gets exposed to traditional chemo, to wait 12 months from a reproductive health standpoint before trying to get pregnant, because we don't want these eggs that have sort of grown up during chemo to form a pregnancy, because those could have an increased risk of malformation. Interestingly, people who conceive at least 1 year after chemo, those eggs grew up in sort of a chemo-less environment, and they tend to do reasonably well and not have an increased risk of malformation. The older chemos, especially some of the ones that are used for bone marrow transplants and breast cancer, they can get into this egg bank, so to speak, and they can wipe away all the materials to make eggs, so there are no eggs left, and then that person is in menopause from that point forward. So one of the reasons we want to think about freezing eggs is, I'm not sure if this will work. Anyway, there's a concept of a reproductive window. So let me show you that. So we usually lose eggs throughout our human lifetime. Well, we're born with about 1 million. So our eggs are all formed by the time we're 20 weeks pregnant in utero. So if this is birth here, all of our eggs are present even before birth. And then by birth, there are about 1 million. And then by the time puberty starts here, in the teens, there are about 300,000. And then menopause is usually about age 50, and then the eggs are gone. And the concern with traditional chemos that would basically take away egg numbers is that if someone got chemo at 21, they might lose all their eggs and be in menopause. Or if they got chemo at 21, they might lose a lot of their eggs and then change this trajectory where the reproductive window is now between wherever they are and 30, so they don't have as much time to get pregnant. Okay, so because people can lose eggs from fertility treatment, either through, in this case, a direct impact on the molecules that are in eggs, or autoimmune therapy toward the ovaries, or toward the targeted cancer but can affect the ovaries, we recommend thinking about fertility preservation options. So egg and embryo freezing or cryopreservation are recommended, and I recommend, in the case of VHL, to meet with a fertility doctor if you have cancer to discuss it. So anybody who's going to get immune therapy or HIF2 agonist therapy, I'd recommend that we chat, and I would recommend that they freeze eggs or embryos. And this is in the absence of having perfect information about it, but this is kind of the current state of affairs. And there's a new guideline that just came out from ASCO that says that kind of when we're thinking about these new molecules, that we want to just use that rational basis that I talked about, and that will inform me saying, hey, yes, think about freezing your eggs or embryos in the absence of perfect information. There might be a significant impact. Dr. Gross could talk more about this, so I won't belabor it, but sperm freezing is recommended. Another option is called expectant management or watchful waiting. So if we lose some eggs, it's still possible to get pregnant. If we lose all eggs, it's still possible to build a family with egg donor, with embryo donation, with eggs that were frozen before, through adoption. There's lots of great ways to build a family. But we don't necessarily have to do any of those things. We can just kind of wait and see, and a lot of people will be okay. So this is an option, I would say. I wouldn't kind of walk around to every patient that is ever diagnosed with cancer in VHL and say, hey, this is a great option, just do this. That would be not good. You want to offer them this. We don't have, unfortunately, any medications that are known to prevent fertility damage from VHL treatment. We'd like to have some. There's science around that in general. They're called fertoprotective agents, but they're not sort of known to work yet. We don't understand their benefit and their risk. There's one medicine that we use to put the ovaries to sleep during conventional chemotherapy, which is called Lupron or Gozerelin. It'd be a potential thing to consider, but in general, there's not like a vitamin or anything to take during VHL treatment. And then there are unfortunately no natural remedies, so no vitamins, no sort of changes to exercise habits or health that will prevent kind of egg count. So if we're thinking about freezing eggs or embryos, as compared to the natural menstrual cycle, I just want to show you what we do with egg or embryo freezing is we just grow a lot of eggs. So this is a usual menstrual cycle. So these are what I mentioned would be like the chocolate chip cookies that we see on ultrasound, the chocolate chips. So these are the little egg houses. So these are called follicles, and each of these has an egg inside. And usually there are a bunch of them, and one egg grows. So with fertility treatment, what we do instead is we give shots that give more of a hormone, follicle-stimulating hormone, to grow more of these. So to go back to my car analogy, a common misconception about IVF is people think, okay, if I'm doing IVF and you give me shots, it will make my eggs better. If you could color these red and green, some of these would be red and some would be green, meaning that some eggs work and some eggs don't, and it's proportional and it depends on age. What we would love is to go onto the factory floor, so to speak, for the eggs. And the cars that have 3 wheels, we'd like to put a 4th wheel on. Like we'd like to be able to fix eggs in their development, but we can't. So the acknowledgement is we can't fix eggs. We know some are normal and some aren't. So we're gonna grow as many as we can to get the greatest number of chances that we can. So this is what it looks like in ultrasound. We do IVF. So you can see maybe why I call it a chocolate chip cookie, but this is the ovary, and these are the follicles or little egg houses when they're big and grown. And then this is a picture of us with a cartoon to kind of clarify, but that's the tip of the needle that we're using when under anesthesia, we put a little needle into these follicles, and then this is fluid, and egg is floating in it, and we suck the fluid out, and that's how we get eggs out of the body. Then we fertilize them. There's 2 ways to do this. One is called conventional insemination. So this is an egg with something called a corona radiata, or cells around the egg that help make it fertilizable, and then sperm would kind of have to swim through this. There's another technique we can use called ICSI, which involves putting the sperm into the egg with a little glass needle. Once we do that, then we develop the eggs and sperm as embryos in an IVF lab. So this is basically when the egg and sperm are together. This is called a 2PN, or 2-pronucleus oocyte. It's also called a zygote. This is the DNA from the sperm, and this is the DNA from the egg, and this fuses together for a half DNA, together whole DNA package. That's basically an instruction book on how to be an embryo. And an IVF lab is just like a fallopian tube. That's how it's designed. So embryos grow in the dark. They grow at 37 centigrade or 98.6 Fahrenheit, and they have fluid that helps them develop from a 1-cell embryo to a multi-cell embryo, and that fluid contains things like sugar and then protein-making amino acids. Okay, so when we make an embryo that's what we call blastocyst, or 5 to 6 days old, it has a polarity. So I describe this to patients as being like a globe. So if this were the North Pole, this would be the future placenta. And if this were the South Pole, or Antarctica, this is called the inner cell mass, or future baby. So one of the things that can come up with a consideration about a cancer risk gene is we could biopsy the embryo. So we can actually sample cells from the future placenta. So the embryo is usually about 100 to 300 cells here, and we take like 5 cells from the future placenta with a laser. Actually, it's like this. We go beep, 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 and then the cells gently detach, and then we take some of them out. And this is a picture of that happening on a microscope. So this is a little vacuum that holds the embryo gently. This is the inner cell mass, or future baby right here. This would be the North Pole of the future placenta, and this is us sampling about 5 cells. So what we can do, if we're looking for a VHL risk gene, is we can take these 5 cells, and then we essentially study the instruction manual, or the genome of the cells. And that is something that is helpful, very helpful, but imperfect. So it's an involved process. It takes about 3 months to do, but it is possible to test human embryos for a VHL gene. We usually need to understand exactly what the gene mutation is, and we need to understand what are called the normal alleles too. So since VHL is autosomal dominant, it means if you get 1 copy of the gene, the baby will get it. So if you can imagine 4 sticks, 1, 2, 3, 4, there's a mutated copy from one parent, there's a normal copy, there's a normal copy from the other parent, and a normal copy from the other parent. We need to understand what's the mutated one, what does each of the normal ones look like, because what we do is essentially we make a little mirror or zipper that binds to the sentence. So in this case, VHL is in the 3rd chapter of the book, so the 3rd chromosome, and it's on, let's just say, page 6 of the chapter. Imagine one sentence that is making the protein for VHL, and people who have VHL disease have a mutation in it. So when I describe this to patients, I would say, okay, the gene is mutated or changed, but how is it changed? We need to understand that well. So if you were trying to make a sentence that said the cat is black, but you said the cat is blick, that would be abnormal. If you said the cat is, that would be a truncated or shortened sentence, that would be abnormal. So those are examples of how you can mutate the sentence or gene. VHL is known to be mutated 370 plus different ways. So there's a lot of ways the sentence can change. And so we don't just have one probe that checks for VHL, it has to be very personalized. Another part of it that's kind of confusing and challenging is that you could say, for example, I grew up near, in Michigan, but sort of near Toronto, and Toronto's big basketball arena was called the Air Canada Centre. So if I was emailing someone to say I want to go to the Air Canada Centre, and I said, I'm going to the Air Canada Centre, and I sent it to someone in Detroit, I'd spell center C-E-N-T-E-R. But if I told someone in Ontario I'm going to the centre, I might spell it C-E-N-T-R-E, since they have some French influence on their English. They both know I'm going to the Air Canada Centre, so it's basically the same message, but it's just a little bit different. So that would be polymorphism or small change that's not a problem. So on those 4 sticks or the 4 genes, we have to know what are the polymorphisms, what's the actual mutation, so that we can make probes. If you can imagine red for the abnormal, blue, yellow, green for the 3 other normals. We want to make sure we know what's normal and what's abnormal. Because when we go to put that little zipper or mirror into the fluid that has the genes from the embryo, we want to make sure that it's stuck and that there's something called allele dropout, which means when we put the probe in, if it doesn't stick but the gene is mutated, we have to infer what's going on because we can't see it directly. So if we put the probe in and it doesn't stick to anything, we might say, oh, the gene's not there, but what if it was there and the probe just didn't stick? So what we want to do in general is prove not only was the mutated one not there, but there were 2 other alleles that are, and it sort of proves to us in a positive sense that we've found normality. The testing for this is basically very good but imperfect. It's usually about 95 to 99% accurate, but we wouldn't tell someone, hey, there's absolutely no way your baby can have VHL. It's important to know, I very commonly encounter this with people, especially with the TikToks and stuff now. Everybody thinks that IVF can check every gene routinely and check for perfect baby health. And so I just have to remind people that firstly, we don't know how babies form, really. Secondly, we don't fully understand the human genome. And thirdly, if we want to check for a gene like VHL, it takes 3 months to check one specific gene. So we can check the book chapter numbers pretty easily, quote unquote. We don't need to know much to just say there are 46 chapters or chromosomes in a book. That's what we can do for everybody. But if we're looking at a specific gene, we got to do a lot of bioinformatic preparation beforehand. Okay, what if somebody didn't want to do that? No problem. It's an option. Other options are to, once pregnant, we can check for VHL through chorionic villus sampling. That just means we're checking the placenta, basically, or amniocentesis, which basically means we're checking the baby or the fluid around the baby, which is like the baby's skin cells. So those can both be options in pregnancy if someone didn't want to do pre-implantation genetic testing. Okay, so let's say we did do genetic testing or not. If someone does IVF and we have an embryo that we've tested outside the body, this little embryo here, this is 0.1 millimeters across, which I just learned is the same distance that fingernails grow every single day. So it's very small. Basically, we put the embryo in through a little tube and we drop the embryo off in the uterus right here so it can implant, and then it works. That's it. Any questions about that? Yes?
Can you speak at all to the cost of this
Sure.
process?
You bet. Yep.
I'm thinking the cryopreservation,
Yep.
And obviously IVF, but is coverage getting any better? Like if someone's on a treatment that forces them to
Yes,
go that
so if someone is getting treatment for cancer, so if someone has VHL and has a cancer diagnosis, then probably 40% of Utah insurers cover it, including Medicaid in Utah. But a lot of them still don't, but that's really rapidly improving, I would say. Where it is more difficult to get coverage is if someone does not have cancer but has VHL and wants to build a family and try this. Now, interestingly, if someone is infertile, like they've tried to conceive for a year is the common marker, and it hasn't worked, some insurers might cover their IVF for infertility. They'd kind of be on the hook then for the VHL genetic testing, but they might have some of it covered. So if you have cancer or infertility, some people have coverage, many people still don't. If you didn't have infertility and you just came in and said, hey, I've never tried to get pregnant, I want to do this testing, that tends to not be covered by insurance. And then it tends to probably cost about $30,000, I would say. And in terms of decision making, this is where we just want to talk to people. Like, it sometimes feels like, oh, the right answer is to use technology and do this. It's not, it's just an option, you know. The kind of general thing we're trying to avoid is somebody that goes through, you know, either they have a baby, they go through cancer treatment, whatever it is, and then 6 years later someone tells them, oh, did you think about doing IVF and checking for a perfect baby? Since TikTok said that. And then they'll be like, oh, I would have done that. I wish someone would have told me that. I would certainly have done that. And a lot of people don't want to do it. Like, we talk to them and they say, hey, I don't really want to do that. And that's totally fine. We just want to talk to them to avoid that moment, because in the moment when someone says, hey, did you think about this? Everyone is like, I definitely would have done that. I wish I would have thought of that, you know? So it is expensive. It's imperfect. It doesn't work every time. But it is a thing to be really hopeful about. It is a great technology. It's kind of how I describe it to people. Then I tell them, like, look, the right answer is the right answer to you, like, not to me. Like, if you decide not to do it, you don't have to. And even my own wife has a cancer risk gene, and we didn't do, even I'm a fertility doctor, we didn't do this kind of testing for our kids. You know, so it's just really personal. So, yeah, any other questions? Okay.
Thank you very much.
Yeah, no problem.
Be great for us to have some information about your clinic, the Fertility clinic,
sure.
just to be able to give it to
Like
patients.
pamphlets or
Yeah,
something? Okay.
yeah, that'd be awesome.